I have the pleasure to introduce Professor Faris Abdul Kareem from Iraq. He is a professor of internal medicine and dean of the Faculty of Medicine at Iraq University Department. Dr. Faris will speak about obesity related to hypertension. سوري دكتور فارس ان احنا طلعنا عليك اكثر من مره، تفضل.
شكرا جزيلا دكتور سليمان. حقيقه شكر للجمعيه المصريه لارتفاع ضغط الدم، خصوصا دكتور سليمان، دكتور محسن، دكتور وفاء ودكتور سليم للدعوه الكريمه اللي صارت حقيقه انه والاستضافه. It is about obesity related hypertension. 15 years ago حقيقه one time when we start working in our obesity clinic in Kidney College of Medicine at that time, a patient presented by her sister. She was a student in our college. As she measured her blood pressure, she was found to be very high. She was 16 years old. His BMI was 38. And when we investigate her by what available of investigation, nothing was found. It is mainly essential hypertension at that time. And we label her as obesity-related hypertension, and that's the starting point why we talk about this thing. The global prevalence of obesity and its associated comorbidities continue to increase on a pandemic scale. Obesity is a significant public health challenge worldwide and is linked to adverse cardiovascular outcome. If current trends continue, the global prevalence of obesity is projected to reach 18% in men and exceed 21% in women by 2025. A growing body of evidence support the notion that obesity is a causative factor in the development of hypertension. Obesity prevalence is more than 30% in our population, and I think in Egypt it's more than 40%, I think. What's the relation? The relationship between excess adiposity and increased blood pressure is well established, and it is estimated that obesity accounts for 65 to 78% of cases of primary hypertension. Framingham Heart study, in which participants were followed up for up to 44 years, showed that increased adiposity accounts for 26 and 28 of cases of hypertension in men and women respectively. And the prevalence of hypertension increased across all BMI levels, with a prevalence of 87% in obesity class 3, more than 40. This slide shows whenever you have more weight, as you see here, and if your BMI more than 30, there is a 42% chance of having blood pressure than BMI less than 25. And as you see, as we say that 78% of new cases of essential hypertension in men and 65 in women were attributable to excess body fat. An increase in weight by 5% only was associated with 20 to 30% increase in the incidence of hypertension. BMI was the strongest risk factor for development of hypertension, with obese women having almost 5 times the incidence of hypertension compared to those with BMI less than 23. A central distribution of body fat is associated with increased blood pressure independently of body mass index. So central obesity is the main factor that affects the patient. There's difficulty in accurately measuring blood pressure in those patients with obesity, as a standard cuff is inappropriate in most cases. And today we talk about the chronic type of arm that is difficult to measure blood pressure in those patients. What's the hemodynamic changes that associate high cardiac output, high plasma volume, and ECG voltage criteria are significantly less sensitive in detecting LVH in obese patients. So this is the pathogenesis of obesity-related hypertension. It is a complex problem, and we will discuss it point by point in a brief way. Mechanisms related to hypertension, sympathetic nervous system overactivation, stimulation of RAS, and alteration in adipose, especially the leptin, insulin resistance, structural and functional renal changes, especially visceral and perirenal fat deposition, obstructive sleep apnea association, hemodynamics alterations, endothelial dysfunction, and impaired renal pressure natriuresis. It is about impaired renal pressure natriuresis. There is increased renal sodium reabsorption plays a major role in initiating the rise in blood pressure associated with excess weight gain, and obese subjects require higher than normal blood pressure to maintain sodium balance, indicating impaired renal pressure natriuresis that may be caused by physical compression of the kidney because of increased visceral, retroperitoneal, and renal sinus fat. So physical compression. RAS activation, including activation of mineralocorticoid receptors independent of aldosterone, and sympathetic activation. What's the functional and structural renal changes that occur with obesity? Visceral and retroperitoneal adiposity can lead to mechanical compression of the kidney. The accumulation of perirenal fat may induce inflammation and expansion of the renal medullary extracellular matrix, which leads to compression of the renal medulla. This results in diminished renal tubular blood flow, which prolongs the duration of time in which fractional sodium reabsorption can occur. So increase renal sodium reabsorption. These compensatory increase in blood pressure and glomerular filtration rate attempt to restore macula-dense sodium delivery towards normal level. Ultimately, however, pressure leads to progressive glomerular sclerosis and impaired renal function, and ultimately renal damage. Obesity is associated with a state also of insulin resistance and hyperinsulinemia, which may contribute to hypertension through several mechanisms. Insulin is a non-to-exert sympathogenic mimetic excitatory effect. Insulin also directly promotes renal sodium retention in the proximal convoluted tubule, and insulin, as it's known to act as vasodilator. However, in obese individual with chronic hyperinsulinemia, this response is blunted secondary to endothelial dysfunction, resulting in increased vasoconstricting tone. So insulin, yes, it is a vasodilator, but in obese patient, because of hyperinsulinemia, vasoconstricting tone. Mild to moderate increase in plasma renin activity and also angiotensinogen, angiotensin converting enzyme activity, angiotensin 2, and aldosterone are contributing factor. RAS activation occurs despite sodium retention, volume expansion, and hypertension, which typically suppress renin secretion and angiotensin 2 formation. Activation of the RAS may contribute to glomerular injury and nephron loss associated with obesity, not only by increasing blood pressure, but also through intrarenal effect. Mineralocorticoid receptors activation in obesity can occur independently of angiotensin 2 mediated stimulation of aldosterone secretion. Obesity generally decreases parasympathetic tone and increased sympathetic with increased heart rate, decreased heart rate variability, and reduce baroreflex sensitivity. Obesity, especially visceral, induce increase in sympathetic activity are usually mild and not sufficient to reduce tissue blood flow. Chronic blood pressure effect on sympathetic activation in obese are mediated mainly by renal nerves. Increased sympathetic activity associated with obesity is not uniformly distributed across all organs and predominantly affect the kidneys and skeletal muscle. Leptin is adipose-derived cytokine that has a variety of physiological function, including the regulation of food intake and energy. Leptin has been shown to stimulate sympathetic activity in the CNS, especially the hypothalamus. Obese individuals have high leptin levels in the absence of weight loss. Insulin resistance lead to hypertension, as it is in insulin resistance. The hypothesis behind obesity-induced hypertension involve the downstream effect of hypothalamic leptin signaling and the activation of a specific melanocortin receptor located on sympathetic neurons in the spinal cord also. So in addition to increasing blood pressure by renal compression and activation of RAS and sympathetic activity, obesity may eventually cause CKD that amplifies the hypertension and make it more difficult to control. A rapid rise in CKD in the past 3 decades has paralleled increased obesity, and there is evidence that obesity may be an independent risk factor for CKD beyond its effect to cause hypertension and diabetes. And what's the treatment? Mainly treatment of obesity. Lifestyle modification aimed at caloric restriction and increased physical activity. Lifestyle intervention consists of dietary adjustment, regular exercise, behavioral modification, but few patients succeed in achieving and maintaining long-term weight loss with lifestyle modification. And obesity also and resistant hypertension link. There is a link between them. 58% of resistant hypertension were having BMI more than 30. Obese patients has significantly increased odds for having resistant hypertension, and the refractoriness among obese hypertensives is infrequently caused by obstructive sleep apnea that associated obesity. For obesity therapy, we have drugs, 5 groups of route for long-term weight management, starting with orlistat, lorcaserin now abundant as an anti-obesity drug because of increasing chance of cancer in those patients who are taking lorcaserin. Phentermine topramate, also another drug. Naltrexone, bupropion, but naltrexone, bupropion increase blood pressure in those with hypertension, and GLP-1 agonist as liraglutide, semaglutide, and tirzepatide. Yes, as you see here, indeed, that in patients with semaglutide, the changes from baseline to week 44 with semaglutide 2.4 milligram in waist circumference, systolic blood pressure, and triglycerides. You see in systolic blood pressure, there is a reduction of -6 between both the groups who are taking or not taking semaglutide, which is very effective in reducing blood pressure, that semaglutide treatment. What's the effect of obesity on hypertension medication? The pharmacokinetics and pharmacodynamics of many medication are also impacted by excess adiposity, leads to abnormal drug handling, expanded volume of distribution, altered hepatic and renal clearance. Individuals with obesity are at increased risk of treatment-resistant hypertension, And all of the above render the dosing of medication often challenging in obese patients. Given the role of the RAS and the inhibitors in the pathogenesis of hypertension, there is a strong case for considering ACE inhibitor and ARBs as a first-line therapy. These drugs have the added advantage of improving insulin sensitivity in obese patients, and also they are nephroprotective. MRAs has also been advocated, although there is little evidence to suggest that these agents show superior efficacy in obese individuals compared with normal weight individuals. And because sympathetic activation is also implicated in obesity-related hypertension, beta blocker would appear to be biologically plausible treatment option. However, it may be associated with weight gain and insulin resistance and should be limited to obese patients with specific cardiovascular indications, such as heart failure or post-myocardial infarction, when beta blocker are indicated. Third-generation agents appears to have fewer adverse metabolic effect in obese patients. Calcium channel blockers of the dihydropyridine class have a neutral effect on glucose metabolism and weight gain, and are usually recommended as second-line agent in combination with ACE or RAS inhibitor. Thiazide diuretics are useful in counteracting the volume overload state in those patients with obesity. Metabolic surgery in the treatment of obesity is common. The most common is sleeve surgery. Next is gastric bypass, adjustable banding, and pancreatic diversion. The effect of metabolic surgery on hypertension, postoperative resolution of or improvement in hypertension occurred in 63% of patients with surgery, with follow-up ranging from 3 months to years. Beneficial effect on blood pressure has not invariably been observed in all studies. So at the first year, the primary outcome, a reduction in the total number of antihypertensive medication by more than 30%, was 6 times more likely in patients who underwent surgery. Remission of hypertension was in which defined as a blood pressure less than 140/90 without medication use was attained in significantly more patients in the surgery group, 56% versus 0%. The patients who underwent gastric bypass were found to have significantly less blood pressure variability at the 1 year and a lower prevalence of resistant hypertension compared to those who received medical therapy alone, 10 versus 15%. And thanks.
Thank you, Dr. Faris. الحيلة بتاعتك الفلور open for discussion.
Thank you very much. Just we have from the beginning to differentiate between 2 types of obesity, and we couldn't lump all obese individuals in one basket because there is abdominal obesity and there is peripheral obesity or lump truncal obesity. For example, obesity in women involves more the periphery, the hips and the periphery, while obesity in men involves more of the abdomen. And there is important and serious differences in these 2 groups. It seems that the type of fat cells which are present in the abdominal obesity, in the abdominal wall, which is present inside the abdominal cavity, are different from fat cells which are present in the periphery. They are different in the means of the cytokines they generate. It has been shown that fat cells in the abdominal cavity generate cytokines which are harmful to the body. And this might explain to some extent why, in general, the lifespan, the life expectancy of women is longer by about 10 years than the average lifespan of men. And this abdominal obesity is the serious one, is the bad one, and we should be very aggressive regarding the presence of abdominal obesity. Unfortunately, according to the data which we collected some 20 years ago, that unfortunately in Egypt we have one of the highest prevalence rates of obesity, particularly abdominal obesity among women worldwide. Thank you.
Yeah, what's expected in women to have less visceral obesity than men. The men who had more visceral obesity, which is metabolically active, that cause more inflammatory reaction.
عشان كده اللايف سبان بتاع الومن اكتر من المن.
Thank you very much. This was a splendid presentation. I would like to ask specific questions to our region, to Iraq, to Egypt. We are always talking about the risk factors which are sent to us from the West. But for instance, in Egypt at this point in time, we're passing through a period of extreme economic disastrous health consequences of patients eating poor diets, of patients not taking their medications, of extremely increased levels of stress. And we know that in the West, like sometimes in the World Cup, just for 3 or 4 days of stress about football, you have major health consequences. So what was the situation of the war in Iraq, which lasted for many years? What was its impact on the blood pressure in Iraq? Was this ever studied, or even as an observation, because I'm sure you have your observations?
Yeah. We have data 15 years ago. It is in 2000, I think, 6 or more, that hypertension prevalence in Iraq was only, I think, 34%. 10 years after, okay, changing. The problem also of obesity is that increasing availability of money also. When you have increasing money, there is increasing obesity. Even in poor countries, there is increasing obesity because of availability of more calories. So whenever you get wealthy, you get also another problems with it. Obesity, hypertension, diabetes, chronic disease, skin and heart disease as well.
Thank you very much, Dr. Faris. Thank you very much.
شكرا جزيلا.
Dr. Fathi.